lucky to have a lot of different options in the first line setting for patients with hepatocellular carcinoma these days, very different from a decade ago. I approach a patient to really assess how healthy they are, what their other comorbidities may be, and what their goals of therapy are. So in general, if a patient is otherwise well and the primary issue for them is hepatocellular carcinoma, I still consider atezo-bev the gold standard. However, a lot of patients with hepatocellular carcinoma have other comorbidities, most notably risks for that go along with VEGF inhibitors. So if patients have had bleeding varices or have large varices seen on CT scan, I often will not consider them a candidate for bevacizumab. Or if they have other risk factors with VEGF inhibitors, such as elderly age, history of stroke, history of cardiac disease, as more and more patients have metabolic-associated steatohepatitis as a risk factor for HCC. So for patients for whom VEGF inhibitors are not a good option, we now thankfully have two different options of doublet immunotherapy, both durva-tremi and ipi-nivo. And then I think it's really assessing the needs of the patient, again, for if a deeper response rate is needed, we might take on the possible suggestion of increased toxicity with ipi-nivo. But many patients for whom VEGF inhibitors are not an option, I am using a lot of durva-tremi these days. Immunotherapy has really changed how we think about toxicity for patients. It is, in many patients, incredibly well tolerated. However, like the commercials say, there are rare but serious side effects, and they're somewhat unpredictable. Although most will happen in the first few months of treatment, they can happen late or even after patients have finished therapy. And it's really quite unpredictable as to who's going to have issues. So as I counsel patients, I said, revat the immune system to get fired up and attack the cancer. But unfortunately, sometimes it can attack the wrong things. Most commonly, the wrong things that it attacks are the lungs or the gut, but it can attack really serious things like the heart and the brain. That can be reversible with steroids, but not always. And in some cases can even be fatal or certainly very debilitating, depending on the effect for patients. So how I monitor patients really is frequent communication. So we make sure that we're checking in with patients frequently. We have a good way for them to access us and encourage them to let us know if anything they didn't think was going to happen is beginning to happen. Lots of availability in our clinic to get in for urgent symptom assessment. I think that's a really good question where I think we have more questions than answers. We know that for some patients, local regional therapy can be quite effective and lead to long-term control of their disease, probably not cure. And exactly how and when to incorporate systemic therapy, especially as systemic therapy has gotten better, I believe remains in general an open question. There are some suggestions that patients will do a little better with the incorporation of local regional therapy on top of systemic therapy in relatively low disease. But I think it is really hard to make a clear conclusion about the best way to sequence therapy at this time. Lots more studies needed. Yes, the adjuvant space has been quite tricky for hepatocellular carcinoma for a long time. even when we had effective results from TKIs, consistently patients really didn't see any benefit from giving TKIs in the adjuvant setting. We had high hopes for atev. Obviously, it's our most effective regimen in a metastatic setting. And there was an initial suggestion that this was going to be helpful for patients in the adjuvant setting with an improved progression-free survival. But unfortunately, the overall survival did not show that there was any tangible benefit, and patients probably did just as well waiting for recurrence to start systemic therapy rather than initiating in the adjuvant setting. And you spare exposing patients to the toxicity who may not actually recur. So it makes sense to see if single agent checkpoint inhibitor in the adjuvant setting will benefit, or a combination like durvalumab or ipi-nivo will show benefit. But I think certainly in the past, we have been disappointed in our ability to help patients following a curative intent surgery.